43, care of the patient with central nervous system problems specific to the spinal cord. I'm going to do this whole chapter in one lecture. I should be able to cover it without going too long. This first slide is just going over the central nervous system itself that you may want to refer back to on the sympathetic, parasympathetic, all those things there. I just included that for you to review. Then the next slide, the chapter goes into back pain on page 885. 80% of the adult population has some sort of back pain somewhere along the spinal cord. Multiple reasons for back pain. Some preventive measures are good posture, proper lifting, exercise, using good ergonomics, using proper equipment, positioning. For pain, using things such as heat therapy, non-steroidals, anti-inflammatory, physical therapy, controlling weight, maybe alternative therapies like chiropractor or acupuncture, different oils, lots of different treatments. This picture here goes over different types: the normal disc, degenerative, bulging, herniated, thinning, osteophytes on here, which can compress the nerve. This shows you the cervical spinal stenosis, which can actually, the stenosis can be anywhere in your spine. Interventions, when the alternatives are other, like rest, positioning, all those are not working, they may do interventional, such as, gotta go on. The spondylothiasis, I put a picture there to show the different stages of it. This picture down here is showing you the sciatic nerve compression, which of course you can have nerve compression as shows here from the cervical coming down multiple nerve roots following the pathway, the particular dermatome. Diagnosis may include plain x-rays, doing MRIs, CT myelograms. Sometimes they have to go in and do arthrograms to get into the joint itself to see where there might be nerve compression coming down. They can do muscle nerve conduction tests and management. They can be injections, like this shows a lumbar disc injury with an epidural steroid injection. And over here I have a picture showing to putting in a stimulator. Of course, there's also non-steroidals, opioids. Often you can combine with different antidepressants with the opioids and non-steroidals to manage pain. On page 887, chart 43.3 talks about different exercises, which really all focus on the core, strengthening the core. Avoidance or limiting the opioids is preferred. Unfortunately, there is a huge opioid epidemic going on in the United States. You can use cold and heat. Deep heat therapy from physical therapy, can do exercises, deep heat with ultrasound. Topical xylocaine, hydrocortisone, some procedures where they use electrical current to help with that nerve pain and relaxing that muscle. Page 891, your text goes into cervical neck pain. If the disc does not herniate, nerve compression may be caused by osteophytes or bone spurs. That was on an earlier picture, on a spinal picture. It can be acute or chronic. It's the same testing, chest, plain x-rays, CTs, MRIs, bone scans, myelograms, EMG, nerve, that's muscle and nerve conduction studies. They do, here is a picture with the anterior fusion, anterior cervical discectomy and fusion, or ACDF, is commonly performed. Page 892 on the top, chart 43.6, care of the patient after anterior cervical fusion. ABCs, always your ABCs, especially in the neck, for bleeding, drainage, swelling, watching their ability to swallow, and then the rest of the spinal cord, able to void bowel sounds, pain management, no leakage of any fluid. If the anterior, you wouldn't have the risk of the cerebrospinal fluid. Specific discharge, teaching, up and walking, movement, following all the instructions. Post-op complications can be temporary. Dysphagia should not last very long. It says it can be up to several months. Some hoarseness due to laryngeal injury when they go anteriorly can be temporary or permanent. Esophageal, tracheal, or vertebral artery injury, wound infections, injury to the spinal cord or nerve roots, dormitic tears associated with cerebral fluid leaks, which is those are more likely with posterior, although they can happen. Or graft and screw loosening if a fusion was performed. Now we're going to move on into spinal cord injuries. A spinal cord injury is damage to the spinal cord that results in a loss of function such as mobility or feeling. I have the picture here with the different dermatomes to show where the nerve roots come. That's pertinent in anything dealing with the central nervous system, especially anything with the spinal cord. Don't need to memorize it, but have an idea where these dermatomes go a little bit. On the right-hand side is a picture of an actual spinal cord injury. They can be complete or incomplete. This picture looks pretty complete. Your text, page 892, starts your spinal cord injury. An incomplete injury is more common than a complete. Mechanism of injury can be multiple things. Your text talks about the different things with the neck and the spinal cord, hyperflexion, hyperextension, penetrating traumas. Here gives you the leading causes of spinal cord injuries, the majority being motor vehicle accidents. Right behind it is falls, and then there's some other violence like like a bullet stabbings, more likely. Your injuries, I say, can be complete or incomplete. The complete is described as permanent loss of motor and nerve function at T1 level or below, resulting in loss of sensation and movement in the legs, bowel, bladder, sexual region. Arms and hands retain their normal function. The different types, you have I told you about the complete lesion, then the anterior cord lesion, where there is position, vibration, and touch sensation. There's part of the cord is damaged, and the parts that are not damaged have the pain, temperature, position, and touch sensation. Brown-Sequard syndrome, there's a loss of pain, temperature, and light touch on the opposite side from the site of injury, and loss of motor function, vibration, position, and deep touch on the same side as the injury. So half the body has loss of pain and temperature, light touch, while the other side has no motor function or deep touch sensation. Central cord syndrome is there's a loss of motor function. Is incomplete loss of motor function in the upper half of the body and loss of motor function in the bottom half. Then there's the cauda equina syndrome. There's a loss of motor sensory function on with various patterns throughout the spine. Okay. Spinal cord injury, this is talking about the different, again, incompletes over here, complete spinal cord injury on this side. The approaches, they may, depending on where it is, try to do a repair. In some of the incompletes, they can do some stimulation, functioning, trying to keep them, get some activity, as much activity as back. That is the goal of the rehabilitation, is to bring back as much independence as possible. As a nurse, you're looking for blood pressure changes because they can be extreme, kidney function, complications. Let's go to this slide. Glasgow Coma Scale is part of your neuro assessment that everybody should be familiar with. Some other parts of your assessment include other aspects of your neurological. Of course, you're checking your cardiovascular, respiratory, gastrointestinal, because the whole entire body has been affected by this. You're looking for shock. You're looking for arrhythmias, throwing of any clots, deep vein thrombosis from immobility of the extremities, respiratory, depending on the level of injury, whether they've lost their diaphragm use, weakness in the respiratory muscles, or paralysis that they're on a ventilator. Gastrointestinal, again, how far down is the level of injury. A big problem is your bladder, and so I put this in here talking about the neurogenic bladder, loss of bladder control. They can also have loss of bowel control, sensation, sexual functioning, muscle spasticity. They can have, I mentioned, paralysis of the breathing muscles in the chest. When they have paraplegia, quadriplegia, the risk of pressure sores, and of course there's the risk of shock. There's spinal shock versus neurogenic shock. The next slide goes more into the neurogenic shock that I said we would talk about. Spinal shock is due to that acute spinal cord injury, absence of all voluntary and reflex neurological activity below the level of injury. It is flaccid. It can last from days to months, but it is transient. It does go away. You might have spinal shock and neurogenic shock occurring at the same time, but they are not the same thing, where your neurogenic shock is actually the body going into shock. This covers it here, but I'm going to go to the next slide. Neurogenic shock, any factor that stimulates parasympathetic activity or inhibits sympathetic activity of vascular smooth muscle can cause neurogenic shock, which results in widespread and massive vasodilation. So I stuck the central nervous system picture in the very beginning. You have your parasympathetic, which is your cholinergic side. So your parasympathetic inhibits the sympathetic. It is the opposite of sympathetic. Your sympathetic is your fight or flight, affecting your rapid heart rate, your breathing, and your vasoconstriction. and your parasympathetic or cholinergic side is where you have a lot of mucus. It does the absolute opposite, so it will constrict your lungs and slow down your heart rate, lower your blood pressure, because everything is dilated. This is just a good picture on talking about this massive vasodilation. So if everything is relaxed, you have a decrease in systemic vascular resistance, or your SVR, and so that decreases your cardiac output, which leads to a decrease in peripheral perfusion or tissue perfusion, cellular perfusion, organ perfusion, and you get that impaired cellular metabolism. You go in the whole shock stage that we talked about, and of course your management is with your vasoconstrictive medications, which I think your norepinephrine, epinephrine, and dopamine, the drugs we talked about in the last lecture, so I'm not going to repeat them here. Then your text, if you look, it has chart 43.8, talks about assessing the motor function of the patient with a spinal cord injury. It takes you through the levels. I have the picture earlier. We're talking about the different levels. You should have an idea of the range, but I don't think you need to know specific levels unless you're going to work in a spinal injury place. But just have an idea where the cervical injury, lumbar injury, what level that they would be paralyzed from there down. You have special immobilization and stabilization section. Of course, you're talking about the halo and devices that we talked a little bit about in pediatrics, and watching your pin site, your care of your wounds, a lot of education, home care, vital signs, looking for infection. This is all things that you should know. There's a section on use of a halo device, chart 43.9. Drug therapy, dextran is a volume expander when you're talking about shock or preventing shock. With the vasodilation, you will have bradycardia, so atropine is to bring your heart rate up. You can have a spastic paralysis, so there's central acting skeletal muscle relaxers such as tizendine to help with that spastic paralysis. Baclofen they can do intrathecal, but into the spine, but it also can be given orally. Baclofen is one of the ones that's very good for spastic paralysis, spastic muscle contraction. Let's see, others. Celebrex, which is, or Celexas, oops, I can't get it out. Celacazib, I guess, is the generic for Celebrex, which is a COX-2 inhibitor. So it is a non-steroidal anti-inflammatory, but as a COX-2, it doesn't block the prostaglandin, so you don't have to worry about the GI bleed with it. Of course, with immobility, you have loss of calcium in the bones and risk of osteoporosis because of immobility and paralysis. So calcium possibly having used biphosphonates for osteoporosis, but there's also risk with those. We talked about possibility of surgery. I'm just moving along here. Autonomic dysreflexia. Let's move to the next slide. This is a good picture for your autonomic dysreflexia. As it says, it's triggered by sustained stimuli at the T6 or below. That is when their bladder is, it says restrictive clothing, pressure areas, but the full bladder, UTI, fecal impaction are the hugest contributors to autonomic dysreflexia. It happens quickly. It is life-threatening. It can happen just from some noxious stimuli that causes the bearing down. It's significant rise in the systolic and diastolic blood pressure. and a great drop in heart rate below 60, profuse sweating above the level of the lesion, especially the face, neck, and shoulders. They have goosebumps above the lesion, sometimes below. There's a flushing in the skin. Everything is above the lesion. They have blurred vision, spots, nasal congestion, onset of severe throbbing headache. Just think of like the middle of the body being constricted and everything above it being way too much. The distended neck veins are sweating, the heart rate, the headache, the mucus, everything. As I said, it is an emergency. You have chart 4311 in your text that talks about the emergency care. Place patient in sitting position is your first priority. Of course, calling a provider or rapid response or a code depending on the significance of the situation, probably a rapid response. Looking for the cause, like doing a straight cath, doing a disimpaction if it's necessary. Consider using anesthetic ointment or tip a catheter before catheter insertion to reduce urethral irritation. Check, it says disimpact if needed, examine skin for new or worsening pressure ulcers, monitor the blood pressure every 10 to 15 minutes. Nifedipine or nitrate, that's to, because they are restricted, you want to vasodilate. And I am aware now, this mentions it too, the bedside bladder ultrasound. It's interesting that they do have those available to scan the bladder to check for fullness. Let's move on. Let's see, nursing focus on the older adult, what patient needs to know about aging and spinal cord injury. You can just look over that. I'm not going to go into that in this lecture. So here, spinal cord tumors, beginning on page 902. You have key features in a chart on 4313. Of course, you're going to have pain if it's depending on, these are just the different types of tumors where they can be located. They may be primary tumors, they may have metastasized from somewhere, and as far as what your symptoms are would depend on where the lesion is and whether it's totally obstructing, compressing the cord. So obviously there's going to be pain, and there can be signs of paresthesia, loss of sensation, loss of movement, and depending on how high or low, if it's up higher, they may lose their diaphragmatic pull. They may not have, they might be as if they are paralyzed from whatever level this lesion is. Primary management is surgery to remove it or decompress it if possible. They may do radiation prior or in addition. They may have to do a partial resection of it or a laminectomy. And of course, post-op, you would do the same neuro checks for any spinal surgery, checking for movements, spinal fluid leakage, drainage, do the proper teaching, sensation, everything you would do for any spinal cord surgery. So let's move on to multiple sclerosis. I thought this was a good picture because it's an immune-mediated inflammatory demyelinating disease of the central nervous system. It's predominantly a white matter disease and a neurodegenerative disorder of the central nervous system that includes the brain, spinal cords, and nerves. It's your immune system attacks itself. It attacks the nervous system and prevents the acetylcholine. What happens is the acetylcholine receptor sites, the immune system attacks them, so there is no receptor for the acetylcholine, so you cannot have the muscle contraction because the stimulus will not pass over and the muscle starts to die out. It just kills the demyelinating sheath of the muscle. It is very progressive. It's most common between the ages of 20 and 40. Treatment options, like it says here, corticosteroids, interferon. They will have paresthetic clumsiness. I have the next slide that goes into more. The fatigue is huge. It's one of the first signs. Nystagmus, optic neuritis, diplopia, dysarthria, trouble with the speech, like I seem to be having, cognitive impaired, depression, unstable mood. It affects everything all the way down, the musculoskeletal, weakness, spasms, ataxia, all the way pain, decrease in your sensation, and or paresthesia with the tingling and burning sensation. It can lead to bowel incontinence, diarrhea, or constipation. Same thing with the bladder retention or incontinence. Management of multiple sclerosis. For the difficulty walking, this gives you some of the drugs. You could see the muscle spasticity. So you have these muscle relaxers, physical therapy, some immune system drugs, lots of Solumendrol, which is a corticosteroid for acute attacks. They may be on corticosteroids orally for quite some time. There's 4 types. The relapsing remitting type occurs in most cases. The course of the disease may be mild or moderate depending on the degree of disability. Symptoms develop and resolve in a few weeks to months, and the patient returns to baseline. During the relapsing phase, the patient reports loss of function and the continuing development of new symptoms. Primary progressive involves a steady and gradual neurological deterioration without remission of symptoms. The patient has progressive disability but no acute attacks. This tends to be between the ages of 40 and 60 for the onset. Secondary progressive begins with a relapsing remitting course that later becomes steadily progressive. About half the people with the relapsing remitting develop into the secondary progressive within 10 years. And then there's progressive relapsing, which is characterized by frequent relapses with partial recovery but no return to baseline. This is only seen in a small percentage of the patients that have MS. We don't know what causes it. It's a complex. It may be viral in nature, but it's something with the immune system attack. Seen more often in colder climates in the Northeast, which is interesting. Don't know why. There's a chart 4314 on page 905 that goes over the multiple symptoms that I had listed on the prior slide, and your text goes more into it. You have an evidence-based practice talking about it. It is prevalent in females, more so than in males, but both can get it. There is no single test to diagnose this. It's diagnosed just by clinical features. They can do a neurological exam, an MRI of the brain. They take the family history. They do a lumbar puncture, may or may not show the IgG antibodies in the spinal fluid. And, let's see, I went over the types, I went over the drug therapy. There's no cure for MS, but treatment aims to reduce the number of relapses or attacks to lessen their severity when they do occur. There's different medications, even chemotherapy drugs. MRI devoted to neurological imaging uses 3-dimensional imaging that determines whether a patient's condition is worsening. If they have spastic muscle spasms, there's baclofen, tizidine, diazepam is used for those spasms, and dantrolene. For optic neuritis, there's methylprednisolone and oral steroids. Fatigue, they'll use antidepressants and amantadine. For pain, often they use codeine, possibly aspirin. It can cause sexual dysfunction, so they may use Viagra. For tremors related to this, isoniazid, primidone, propranolol, so that's a beta blocker, and the others affect the musculoskeletal system. And the disease-modifying drugs or DMARDs, such as interferon, that are used. Interferon interacts with the receptors on non-infective cells to promote the synthesis of antiviral proteins that prevent further infection. Okay. Nursing assessment is focusing on their respiratory, their swallowing, and musculoskeletal, depending on the degree of limitations and progression. This chapter also has a concept map on multiple sclerosis. If I were you, I would look over this. It's very good on looking on your outcomes, what kind of problems they face as the nursing safety, your assessment for your sensory, their mobility elimination, drugs, managing the dysphagia, and all that. So I would look over that. It's very detailed, very helpful to get you a good picture of what this disease is and what the management is. I'm going to move on over now to the last part of this chapter on amyotrophic lateral sclerosis, or ALS, sometimes known as Lou Gehrig's disease. This is a good picture of showing it. It's a progressive neurodegenerative disease, and it is 100% fatal. It affects the entire body. It affects the ability to talk, swallow, and breathe. It's a result of loss of lower motor neurons found in the spinal cord and brainstem, and the muscles to which they connect begin to weaken, atrophy, and die. They also have loss or death of the neurons in the brain. They have spasticity in the muscles. Death typically occurs within 3 years of diagnosis due to respiratory arrest. It is an incurable disease. This shows you the progression of it. Usually affects between the ages of 40 and 60. 5 in every 100,000 people worldwide. Chart 4315 goes over the early signs. Fasciculation, which is twitching of the face or the tongue. The muscle atrophy in the arms, weakness in the hands and the arms, tongue atrophy. Dysarthria, which is an inability to speak, form the words, a slurred speech, nasal quality of speech, dysphagia, trouble swallowing, all in that upper part of the body, difficulty controlling crying or laughing, what they call emotional incontinence. I think that's a good word for it. Diagnosis is based on clinical and diagnostic findings. They try to rule out everything else. There is no specific test to diagnose ALS, but creatine kinase, which is released from muscle wasting, will be elevated. They can do EMG to show this fibrillation of the muscles and the wasting of them. There is no cure. Interdisciplinary approach for maintaining optimum function until the end of life, but is said from onset to 3 years of living. There is the only drug approved at the moment, this Riluzole for ALS patients. It's not a cure, but it does extend survival time. Remind the patient to take the drug when the stomach is empty. Teach the patient how to detect signs and symptoms of liver toxicity, such as vomiting and jaundice, that the drug may cause. Frequent liver enzyme tests, that's your ALT, AST, alkaline phos. Let's see. They should be prescribed medications for pain, fatigue, the muscle spasm drugs that I mentioned for MS would also apply here. Speech therapy, care, palliation of terminal restlessness, confusion, hypopnea. They may use some neuroleptics such as Thorazine. Okay, and I guess that's about it for here. So that is the end of chapter 43, and we'll continue the nervous system in chapter 44, talking about the peripheral nervous system.